The disadvantages are that if you're developing some mild arthritis in other parts of your knee, you could still have some pain, or your arthritis may progress over time. Let's say that you have a fairly normal looking knee regarding the rest of it that wasn't replaced at the time of surgery. Over the course of time, 3 or 5 or 7 or 10 years, you could develop arthritis in those parts of the knee, which would make you unhappy with your knee replacement and have to have it replaced or swapped out for a total knee replacement. And so when we talk about this in the office, which is a conversation that I have many times every day, we have to talk about the pros and cons of what's likely to happen with your knee and what may happen with your knees. If you're on the bubble, meaning that you're really, really wanting a partial knee replacement for a number of reasons, but I see that you're developing arthritis in one part of your knee, and I'm concerned about the progression of that over time, I'll probably push you towards a total knee, because ideally you'd like the first surgery that you have on your knee to be the last surgery. At least the first surgery that I do, I'd like for it to be your last surgery, because nobody wants to go through this over and over again. The advantages of a total knee replacement, on the other hand, is exactly that if you have the whole knee replaced, there's nothing left to replace. It's like having the whole engine rebuilt. You can swap out a piston or a ring, and then other parts can go bad, or it's like buying a new car. Once it's replaced, you have a new knee, so it's likely to be your last replacement. And in general, we have much more historical data, historical information on total knee replacements. Literally millions of total knees have been implanted, whereas really just hundreds of thousands of partial knee replacements have been implanted. So we can go back through different types of devices, geographic regions of the country, parts of the world or what have you, and we have lots and lots and lots of data on total knee replacement, whereas the results of partial knee replacement is not as robust. We don't have as much information. So we can tell you with a lot more confidence what will happen with a total knee than we can with a partial knee. The disadvantages of total knee replacement is that the surgery is more complex. There's a little bit more work involved. It's technically more demanding to implant one of these devices, and so most patients do have a little bit more pain and swelling initially. The hospital stay is longer. It's still not long. I mean, most patients at this hospital go home after the second day rather than the first day. Our average hospital stay here, and we've done close to 2,500 joint replacements here since we opened, is something like 2.3 days, I believe. So it's still not forever, but it's a day longer. And the recovery can definitely be a little bit more difficult. Partial knee replacements typically come into the office 2 weeks after surgery to get their stitches out, and they're walking fairly normally and relatively happy with their knee, whereas the total knee replacements may still be using a walker or a cane or something to help support their weight and assist them, because they just haven't quite gotten there yet. So which is better? Well, that depends on a whole variety of factors. In my practice, and I do probably about 120 to 150 knee replacements annually. I do lots and lots of knee surgery, but 120 to 150 knee replacements. About 10 to 15% of patients that I see for arthritis are candidates for partial knee replacement. So by far and away, the majority of people that need knee replacement surgery are better served by a total knee replacement. So we've talked now about types of implants. That was the first broad category that I wanted to cover. And now we're going to talk a little bit about technique, or the way that we put these implants in, because I think that's every bit as important, if not more important than the type of implant that we use. And so I'd like to talk to you about just a few abbreviations that we use. One is computer-assisted surgery, or CAS. And I'm going to talk to you about how I use computers to help me implant these devices. And then we'll talk about patient-specific instrumentation and patient-specific implants. That's really been the big jump forward in technology, in my opinion, over the last several years. And that's something that we use commonly here at this hospital. So what is computer-assisted surgery? Well, on the left is the actual computer that we own here at this hospital. It's made by a company called Stryker. And it's got this little sort of sensor here that senses electrical signals from these pins, or these devices that we implant into the knee right before surgery. And what it does is it sends signals out to the camera. The camera then registers those signals in a complex way that I don't completely understand. And then it generates a virtual three-dimensional model of the knee. And so about 5 maybe even longer than that, 6 or 7 years ago, we started using this device, and we used it commonly in almost all of our surgeries. This is really cool if you look at it. I mean, this is high tech, and it seems to give you a lot of information that we wouldn't have otherwise. The problem with using this computer, as with any computer, is that, guess what? Sometimes you turn it on and what happens? Nothing, right? There's nothing comes on. Or you'll get everything set up just perfect, and in the middle of surgery, you start getting, errors in your data reads. And so, even though it's a great piece of equipment, and there are still doctors that use this nationally, this has fallen, in my opinion, somewhat out of favor because of the unreliability of computers. And furthermore, this is a very, very expensive piece of equipment. I don't even know what it costs, but it's, I think, well over $1 million. And the information that was coming out 3 and 5 years after this was starting to be commonly used was that it didn't really improve the outcomes of knee surgery significantly. I mean, the knees were a little bit better aligned, there's no question about that, and they were a little better sized, but the patients that had it didn't feel any different. So hospitals and doctors had a hard time spending $1 million for a piece of equipment that didn't always work and didn't seem to make a huge difference. So even though we still have this piece of equipment, not sure where it is exactly, but we still have this piece of equipment. I personally don't use it. One of my partners still uses it occasionally for some of his knees. And I'll use it in very rare occasions for specific problems that I don't really want to go into. But by and large, this is just something that we don't use so much anymore.